Hello, Assalamu alaikum. Hello, my dear student. How are you all? I am Dr. Muhammad Ruhul Amin, Registrar Department of Medicine, going to discuss about thyroid disorder, that is thyroid hormone analysis. In my last class, we have a discussion regarding thyroid hormone analysis in a simple way, in a easy way. Today, we will discuss a bit of thoroughly, and I hope it will be interesting one if we go through from the very beginning to the last. In your final profession examination, thyroid hormone analysis may be found in your board examination. That is when you will be given a data. Even this kind of data you may find in your OSP examination, and in your written examination you have to face various questions regarding thyroid hormone or thyroid hormone and thyroid disorders. So I think it is really important for those students who are going to face the final profession examination within very short space of time. Thyroid hormone analysis or thyroid hormone disorder is always a really challenging one. It is very hard for doctors or medical student to have a description on thyroid hormone. So it is always in a way of knowing something regarding thyroid hormone or thyroid disorder. If we don't know how to interpret it, it is almost impossible for one to have a description. On the basis of your idea, on the basis of your basic knowledge, it is very hard for one to have a discussion. So we will try to have a description thoroughly. So thyroid hormone disorder or thyroid hormone analysis interpretation, we have to know anatomy of thyroid gland, physiology of thyroid gland, thyroid hormone synthesis, pathology, medicine, various things are related regarding thyroid hormone. This picture shows a thyroid hormone anatomy, a position. This cricothyroid membrane, thyroid cartilage, loops, loops of thyroid gland, and carotid arteries. All of these things are very much important for surgeons. Dear student, please use your headphone for better sound quality because there are some technical problem here. Thyroid regulation. As we know, this is thyroid gland, thyroid hormone. Hormones are synthesized here. And it is this thyroid gland under the influence of antiropituitary by TSH, that is thyroid stimulating hormone. And again, this antiropituitary is under the influence of hypothalamus by TRH, that is thyrotrophin releasing hormone. So all of these things are interrelated. Whenever a signal will come from hypothalamus to antiropituitary to thyroid gland, After that, thyroid gland will start synthesis of thyroid hormone, that is T3, T4. And after synthesis of these thyroid hormone, it will come into a periphery and it will start erection. Look here, T4 is again converted to T3 and reverse T3. This T3 is active form. It will act on our various tissue and have functional entities. Look again, hypothalamus, anteropituitary releases thyroid TSH, then thyroid gland synthesis T4, T3, plasma T4, that is FT4, that is free T4, and plasma T3 and free T3. The tissue level T4 and T3 and reverse T3. In the thyroid gland, there are the following 5 steps in the hormonogenesis: trapping of inorganic ion from dietary iodide, activation of iodine to high valence iodine, incorporation of iodine into tyrosine of thyroid globulin, coupling of formed MIT and DIT to form T4 and T3, monoiodotyrosinase and diodotyrosinase. Proteolysis of thyroglobulin to release T4 and T3. That is, after entering into the body, iodine trapped in the thyroid gland and entered into the thyroid gland through various mechanisms, and where it helps to synthesize thyroid hormone and it is stored along with thyroglobulin. And when thyroglobulin have proteolysis, then it release the T3 and T4 to the blood. So you may have a question to me that what is the importance of this? If we know these hormonogenesis steps, it is very easy for us to understanding the basic pathology of thyroid gland. If there is problem here, there may be hypothyroidism development. If there is excess iodine enter into the thyroid gland, there may be chances of hyperthyroidism. Even after synthesis, if there is problem in thyroglobulin, or if there is problem in the release of T3, T4, there will be chance of development of hypothyroidism. Metabolism of thyroid hormone. Thyroid gland, look, thyroxine, that is free T4, thiiodothyronine, thyroid gland, reverse T3, again T3 converted from thyroxine, and this T4 may be converted to reverse T3. It is the mechanism or pathogenesis what happens in fluorosis. There is no need in this time. The thyronines, monoiodo, tyrosine, MIT, diiodo, tyrosine, DIT, thiiodothyronine T3 half-life 6 hours, tetraiodothyronine this T4 half-life 7 days. So it is very high half-life. The thyroxines, thiiodothyronine, T3, the 10% from thyroid gland, 90% derived from conversion of T4 to T3. So it is very important knowledge. We have to know it. tetrahydrothyroid T4 is exclusively from thyroid gland. So whenever there is a problem in thyroid gland, there will be problem in synthesis of T4. From the thyroid gland, 80% of hormone secreted is T4. 20% of hormone secreted is T3. So it is very important to know that 80% of hormone secreted is T4. What are the thyroid function tests? TSH, free T4 and free T3. With the help of these three tests, we can explain a thyroid hormone. Non-specific laboratory abnormalities in hypothyroidism. In hypothyroidism, I mean, perform some investigation like serum enzymes, hypercholesterolemia, anemia. Anemia we may found in normocytic anemia, macrocytic hyponatremia, so many things. And various tests are done in case of thyroid hormone disorder like radioimmunoassay, ELISA, chemoimmunoassay, and so much so on. We have to decide it on the basis of our clinical picture. So it is really important to know how to interpret results. This part is very much important for all of us. The 9 square games, it is like a game. With the help of a game, we can evaluate a thyroid hormone, or we can explain a thyroid hormone. Basic thyroid evaluation. Look, thyroid stimulation hormone in this x-axis, free thyroxine or FT4 in this y-axis, x-axis, y-axis. Look, thyroid stimulating hormone, low, normal, high. Look, low, normal or high. Free thyroxine, low, normal, high. That means this axis will guide TSH, low, normal, high, and this axis will guide T4, low, normal or high. Euthyroid. Look, TSH normal, TSH normal, T4 normal. Look, if we look this axis, normal TSH, normal FT4. So it is euthyroid. Euthyroid. So whenever we found a thyroid hormone reports dictating TSH normal, T4 normal, we can assume that this may be a reports of euthyroid. Look, thyroid stimulating hormone high, thyroid stimulating hormone high, primary hypothyroidism, free T3, free T4, free T4 low, primary hypothyroidism. So there is a problem in synthesis of thyroid gland. So as we know, thyroid 80% FT4 is synthesized from the thyroid gland. So low, this low T4 give a stimulatory effect to entropituitary to synthesis TSH. So it is high and it is primary hypothyroidism. Look, TSH low, but FT4 high. So it is problem in the synthesis of T4. So more T4 is synthesized, so it gives a negative inhibitory stimulation to thyroid stimulating hormone, so it is low. So it is primary hyperthyroidism. FT4 high means hyperthyroidism, and TSH low, there is primary hyperthyroidism. Look, TSH low and free T4 is low. So it is secondary hypothyroidism. If we look toward this picture, look, if TRS is high, TSH high, thyroid hormone synthesis high, it is secondary. If thyroid hormone high but TSH low, it is primary. Whenever thyroid gland himself problematic, it is primary. And other than if thyroid gland is involved due to the other external cause, it is secondary. Now look, here is TSH high and T4 high, so it is secondary hyperthyroidism. TSH T4 high, T4 high, TSH high. That means high TSH, high thyroid hormone. That is thyroid hormone is synthesized due to the stimulation of antipituitary. So the stimulation is from external side of thyroid hormone, thyroid gland. So it is secondary. If it is problem in the gland itself, it will be a primary. Look, subclinical hyperthyroidism. FT4 normal, but TSH low. As we know, if TSH is low, it is 2, FT4 should be high. But in this case, it is normal. This is termed as subclinical hyperthyroidism. Look here, TSH high, but as we know, if high TSH, there should be high T4, but it is normal. This is termed as subclinical hypothyroidism. Look, TSH normal. In that case, it should be free T4 should be normal, but it is low. Why it is low? Due to the illness which causes a problem to conversion of thyroid hormone. So it is non-thyroid illness or NTI. If you look meticulously, it will be very easy for you to understand. No need to know that. So look towards here. If if we look this axis and this axis, primary hyperthyroidism, secondary hyperthyroidism, primary hypothyroidism, secondary hypothyroidism, subclinical hyperthyroidism, subclinical hypothyroidism, euthyroid state. It is very nice, nice game to understand the basic thyroid evaluation. The normal reference range of thyroid hormone TSH 0.3 to 5 milliunit per liter and 54.7 to 2.1 nanogram per deciliter. TSH upper limit will soon be revised. Thyroid function test in progress hypothyroidism. There is the nucleotide scintigraphy. You know that you should know this, the name of this investigation, scintigraphy. With the help of scintigraphy, we can diagnose a Graves disease, a hot or cold nodule or dark in this thyroid disorder. So many various disorders are identified with the help of nucleotide scintigraphy. Thyroid antibodies, we should know some the name of thyroid antibodies like thyroid antithyroid peroxidase, TPO antibody, antithyroid antibodies, and thyroid stimulating antibodies. If these antibodies are involved in the synthesis of causing the disease of various type of thyroid disorder like Hashimoto's thyroiditis, Graves' disease, and so on. Hypothyroidism is simply a presentation, as we know, that of an unsuspected and grossly underdiagnosed. 90% of these cases are primary hypothyroidism. In case of female, menstrual irregularity, miscarriage, growth retardation, back pains, anemia, lethargy. So many clinical manifestation may occur. Hypothyroidism, autoimmune, iatrogenic. There is so many systems are affected in case of hypothyroidism or thyroid disorder like neuromuscular, gastrointestinal, dermatological. It is very important to know as the thyroid failure organ system. In case of thyroid failure, there is thyrotoxicosis. Which organ may be involved? Cardiovascular system, causing decreased ventricular contractility, increased diastolic blood pressure, decreased heart rate, central and nervous system, decreased concentration, general lack of interest, depression, gastrointestinal, decreased GI motility, constipation, musculoskeletal system, renal system, reproductive system, hepatic system, even skin and hair may be involved in case of thyroid hormone disorder, like a thickening and dryness of skin, dry, coarse hair, alopecia, loss of scalp hair and or lateral eyebrow hair. There are various types of comorbidity are involved in the thyroid hormone disorder like hypercholesterolemia, depression, infertility, menstrual irregularity, diabetes mellitus. And today we are giving a bit of importance in discussion on hypothyroidism. Hypothyroidism and depression. So it is very important for us to know that if we found a patient of depression, we should uh, go through the evaluation of hypothyroidism. In case of suspected hypothyroidism, we may find amenorrhea, oligomenorrhea, menorrhagia, galactorrhea, premature ovarian failure, infertility, decreased libido, precocious or delayed puberty on a chronic urticaria. In case of hypothyroidism, we have to maintain some algorithm to diagnose it. TSH will measure TSH, then if elevated TSH, what to do next? Measure 54. If 54 is low, then what to do? Primary hypothyroidism. If we will perform thyroid peroxide antibody, if thyroid antibody positive and thyroid antibody absent, if thyroid TPO, there is thyroid peroxide antibody positive, it may be a case of Hashimoto's thyroiditis, and at the time we have to perform T4 again. If thyroid peroxide is negative, we have to think otherwise. After measuring T4 it is normal, this may be a case of subclinical hypothyroidism. Then we have to perform again thyroid peroxide antibody. If it is positive, we have to repeat the T4 level. If thyroid peroxide is negative, we have to perform annual follow-up. And in this algorithm, if thyroid stimulating hormone normal, we have to consider pituitary disease. If pituitary disease is absent, we should not perform and tests regarding the pituitary disease. If pituitary disease is suspected, then we have to perform again measurement of free T4. If normal, no test needed. Low, then we have to perform evaluate pituitary seek euthyroid or drug effect. In case of treating hypothyroidism, we can give some treatment, levothyroxine, being monitoring of TSH level. Dose adjustment is very much important. We have to start from low dose and gradually it will be titrated. In case of treating thyroid disorder, we have to think in our mind that there are various drug interaction. So treating other condition at the time of thyroid disorder, we have to think about drug interaction like cholestyramine resin, sucralfate, ferrous sulfate, aluminum hydroxide, so many things, even rifampicin, carbamazepine, phenytoin, phenobarbital, amiodarone. All of these are very much important, creating various type of drug interaction at the time of treating thyroid disorder. And dose should be appropriate. Inappropriate dose will create other problem, maybe over replacement or under replacement. All of these things are problematic for thyroid disorder. So diet should be planned. In case of iodine deficiency, we have to give iodized salt, selenium supplementation, avoid cassava, avoid cabbage, avoid formula milk, fish, meat, and milk and eggs. Subclinical hypothyroidism. It may be chronic autoimmune thyroiditis, Graves' hyperthyroidism with radioiodine or surgery, inadequate replacement therapy for hypothyroidism, and lithium carbonate. It is very much important to know the term subclinical hypothyroidism. We have discussed earlier what is subclinical hypothyroidism. Postpartum thyroiditis, it is very much important to know in case of female. Myxoedema coma. What is myxoedema coma? Hypothyroidism. Rare, it is really a rare representation of hypothyroidism. But if it is diagnosed, it is a medical emergency, we have to manage it very meticulously. There are various specific factors, signs and symptoms, treatment, look here, IB, seek euthyroid syndrome, yeah, total T3 reduced, free T4 reduced, total T4 reduced, and free T4 normal, TSH normal, clinically euthyroid. We have discussed earlier in the DICE game what is seek euthyroid syndrome. You know just know the term. So, dear student, this hormone examination report, we have discussed it earlier. If we look toward this report very meticulously, you will find that TSH, T4 and T4 and T3. If we look these primary hyperthyroidism, look here TSH low but T4 high. In that sense that here is thyroid gland is synthesize excess T4 and it gives a negative inhibitory feedback to the anti-pituitary that don't synthesis more and more TSH, so it is low. It is primary hypothyroidism. So if you look toward this, that TSH low, T3 and T4 high, so it is hyper or hypo, definitely hyper. Is primary or secondary? It is primary. So in your final professional examination or even in the OSPE examination, you may find this kind of data. I think it will be very easy for you all to explain it. Whenever we will find it, we have to go through very beginning to the last: name, age. As we know, the thyroid hormone disorder are mainly affected by people, um, affected by more female than male. It is Mrs. Rumi, that is female, younger age patient. So it is primary hyperthyroidism. Look, primary hyperthyroidism. In this way, we can explain more and more and more and reports of thyroid hormone, thyroid hormone analysis. Today we have discussed a lot regarding the thyroid hormone and hypothyroidism. In the next class, we will discuss regarding thyroid hormone, the remaining part, and along with CSF examination. I think it will be help a great deal for the students of final professional examination and those who are facing the final professional examination within very short space of time. You can go through your books and find the thyroid hormone, thyroid disorder, and just have a glimpse, just have a read over the books, and I think it will be interesting and easy for you to have explanation regarding the thyroid hormone analysis. Although thyroid hormone is always a very challenging one for one for explanation. If you don't know, it will be very hard for you to explain something. That is, you know or you don't. If you don't know, you will not be able to explain anything. So, from the on the basis of today's class, I think it will be very easy for you all to have an explanation on thyroid hormone. If you have any question, just send question to my to our WhatsApp group or send a question to my Facebook inbox. I do have an answer, inshallah. Till then, take care. Goodbye.